Welcome, everyone, to the Sarah Taub Memorial Webinar 2026. Our topic today is person-centered supports. How does paid family caregiving measure up? And this webinar is jointly sponsored by the Human Services Research Institute, Advancing States, and the National Association of State Directors of Developmental Disability Services. Next slide, Lindsay. Hi, I'm Val Bradley. I am a white woman. I have red hair. I am in what we call now my golden years. I'm sitting in my office with a bookcase behind me and lots of plants. And luckily, here in Cambridge today, it is sunny.
Hi, everyone. My name is Lindsay DuBois. I am a white woman in my late 30s. My pronouns are she, her. I have blondish hair. It is mid-length and wearing glasses and a beige sweater. And behind me are lots of colorful pictures drawn by my children.
Hi, everyone. My name is Rosa Plasencia. I work at Advancing Stage, which is the Association for State Aging and Disability Agencies. I'm a woman in my early 40s with dark brown, wavy hair, glasses, and a blue sweater. You might see the cat that I have on my lap jumping up on from time to time, and my background is blurred.
Hi, everyone. I am Laura Vegas. I am a white female with shoulder-length brown hair. I'm wearing glasses and a blue shirt with white polka dots. And I work for the National Association of State Directors of Developmental Disability Services. And I'm so proud to be part of this NCI collaboration and welcome you to today's webinar.
Hi, my name is David Watkins. I'm a white man, bald, in my 60s with a beard, wearing glasses. I work for the Georgia Division of Aging Services.
Thank you. Participants will be muted during this webinar. Please use the question and answer, the Q&A feature in Zoom to ask questions and communicate via chat with the hosts, that's us. The webinar will be captured in English and interpreted in Spanish and ASL live. Live English captions can be accessed by clicking the CC button at the bottom of your Zoom screen. Live Spanish interpretation can be accessed by clicking the interpretation button at the bottom of your Zoom screen, which is the world icon. Once in the Spanish channel, please silence the original audio. Se puede acceder a la interpretación en español en vivo haciendo clic el botón Interpretation en la parte inferior de la pantalla de Zoom, icona del mundo. Una vez en el canal español, por favor silencio el audio original. For full accessibility, including interpretation, may not work if you are joining from a mobile device. Please swipe on your device to find the ASL interpreter if you need to. The live webinar includes polls and evaluation questions. We'd very much appreciate your participation and engagement during that section. The webinar will be recorded and posted to YouTube at a later date, and the slides will be available on our website. Back to you, Val.
Hi, all. Yes, and I am the President Emerita of the Human Services Research Institute. And it's my pleasure to introduce our old friend, Sarah Taub, a good friend and colleague of those of us at HSRI. And certainly she had contacts around the country, NCI people who collaborated with her. She was the director of the National Core Indicators until 2013, when her life was cut short by a very aggressive cancer. She had an incredible sense of mission and purpose and was really the heart and soul of NCI and essential to its growth over the time she worked with us. She was a fierce advocate for people with disabilities and for their representation at all levels of what we do as an organization. She continues to be missed, And we thought it was important to keep her name alive by calling these webinars the Sarah Taub Memorial Webinar. Thank you, Sarah. So what are we going to talk about today? First, I'm going to introduce a few issues related to family caregiving, and then we're going to talk about how to measure the quality of paid family caregiving using data from NCI. Then Georgia will tell us about how they've enhanced paid family caregiving in Georgia, and then we're going to talk about some future directions. So let me introduce you to a few issues related to family caregiving. First of all, significantly and almost staggeringly, 1 in 4 Americans, that's 63 million adults, currently provide some form of ongoing care for aging parents, spouses with chronic conditions, or adults or children with disabilities and serious illnesses. A recent estimate suggests that only about 4% of family caregivers report that they are getting paid for the care that they provide to their loved ones. And that same study in 2022 suggested that the economic value of unpaid contributions was around $600 billion. So you can see that so far, the paid family caregiving slice of the Medicaid program is quite small, although recently we believe it's become somewhat of a target for those at the federal level who are trying to expose fraud, waste, and abuse. Next slide, please. State family caregiving policies. In Medicaid state plans and HCBS waivers, states have wide discretion about what types of services are covered and whether families can be paid to provide supports. During COVID, we saw a growth in paid caregivers. 27 of the states used their temporary flexibilities allowed during COVID time to allow family caregivers to be paid providers. And of that 27, 17 made those flexibilities permanent. What's the current landscape of the workforce in LTSS? I think all of us have been aware over many years that the crisis in our workforce is nothing new and was only exacerbated during COVID. What we know because of this crisis, many programs are unable to accept referrals because they don't have enough staff to support them. And we also know through our own surveys that some programs have had to close various aspects of their offerings because they're unable to find the staff to provide the services. The One Big Beautiful Act cut federal spending on Medicaid and Medicare and now requires states to balance cost-cutting strategies while trying to maximize outcomes for LTSS users. So there's virtually every state in the country now attempting to make these Hobson's choices about how to restructure the resources in the program. And we believe that understanding how the outcomes differ among LTSS users who rely on paid family caregivers versus paid staff can help inform state efforts to enhance LTSS, while at the same time easing to some extent the workforce crisis that we're all experiencing.
Thanks for that framing, Val. I'm going to share some of the background and context about the National Core Indicators to help frame the topic that we're talking about today. To go ahead and get started, here we go. So at the foundation of National Core Indicators is really our people-driven data. To gather this, interviews are completed with people who have disabilities and older adults who receive their services from their state intellectual and developmental disabilities or aging or physical disabilities systems. Hearing directly from the people who receive the services is really just very critical to help us learn how the services impact people and their quality of life. It also helps states quite a lot to understand what is going well and what needs to be changed within the systems that they control. Next slide, please. The National Core Indicators has an established history supporting data-driven decision-making. There is a timeline on the slide that shows how almost 30 years ago, NCI-IDD, or intellectual and developmental disabilities, came into being. First with the in-person survey and followed by the children and family surveys. Remarkably, 48 states and DC have participated in the NCI-IDD surveys. NCI-AD, Aging and Physical Disabilities, arrived about 10 years ago. We just celebrated our 10th birthday, with over 30 states participating since we began. Alongside the quality of life surveys, State of the Workforce was launched. First with the IDD system, which is the intellectual and developmental disabilities, and then with aging and physical disability populations. With these surveys, we gather information about the direct service workforce and direct service professionals in 30 states. Next slide, please. So you'll see a few elements that are listed on this slide. The NCI surveys gather many different data elements through the two sections of the survey. We have one section gathered from state administrative records, which is on background information, as you can see in the top left-hand corner. Other areas of information are gathered through interviews and include a wide array of areas, such as individual outcomes, system performance, and health, wellness, and rights. As you can imagine, there are many possibilities and uses that states have for this data regarding quality oversight. Next slide, please. National Core Indicators is also recognized nationally in many different areas of quality monitoring. I'm going to read through a few that are on the slide. NCI is included in the HCBS, which is the Home and Community-Based Services Quality Measure Set, which was set forth by the Centers for Medicare and Medicaid Services and required by the Access Regulation. NCI measures are endorsed by the CMS, which is the Centers for Medicaid and Medicaid Services, consensus-based entity, which used to be the National Quality Forum and is now managed by Battelle. NCI IDD in-person survey measures are included in the CMCS adult core set. And NCI IDD, the adult and the NCI AD surveys are also included in the Medicaid and CHIPS scorecard, as you can see on the slide. And NCI AD participation is included in the AARP Long-Term Services and Supports States scorecard. Sorry for a few of the acronyms on there. States also use NCI AD in older American Act areas in order to look at their quality oversight. You already got the other slide, thank you. So I mentioned that NCI AD just celebrated its 10th anniversary with the Adult Consumer Survey, which is intended for older adults and people with physical disabilities. Our national project team works with participating states to help them to design a sample that is representative of their service populations. Included, in order to be included as an individual, has to receive at least one service 2 times a week. And our team trains surveyors so that their methods are consistent across states. You can go ahead and jump to the next slide, please. This is a slide where you can see some of the information that our most recent state participation and the people who were represented in that. We're really proud that over 20,000 people took the time with our interviewers in order to share their experiences with the long-term services and support system. There are some demographics that are example on the slide, such as 64% were female, and the average age was 60%. And you can also read a little bit more about the race and ethnicity and the diagnosis. I'm going to turn about the rest of these to you. Lindsay, thank you.
Thanks, Rosa. This is Lindsay. And what's really exciting about this data is it's our first time presenting it. So we hope you enjoy this and have some great takeaways. I'm going to move to the next slide. All right, so when we take a little bit of a closer look at those 20,000 NCI AD respondents, we see that the majority live in the community. They live in their own or their family home. That's 77%. Another 10% are in those assisted living, senior living centers, and then 4% in nursing facilities. When we look a little bit more closely at those who live in their own or family home, it's important to understand if they have live-in support with them through family members or other types of supporters. And we see that more than 1 in 4 of those people, 30%, actually live alone. So when we think about what that might look like for people's outcomes, this is just important context. We also see that the majority of people we survey do get regular ongoing support in their homes. So we ask them, is there someone who helps you at home at least once per week? More than 9 in 10 say yes, there is someone who comes to help them. We also want to think a little bit about how much support people need. That's really important when we're understanding their outcomes. So when we look across the sample, we are asking people about the amount of help they need with those activities of daily living and self-care. And we see that overall, 2 in 3 people need a lot of help with ADLs, and nearly half need a lot of help with self-care. There's also another 29% that say they do need some help with ADLs, and 31% that need some help with self-care. So when we think about the needs of the people we're speaking to, there's absolutely supports needed, they're ongoing, and who provides those supports might have an important impact on their outcomes. So who does provide the support, right? So we ask people, who helps you most often? And we see 2 in 5, or 40%, tell us a paid family member or friend is the person who helps them most often. Another 44% tell us a paid support worker is the person who helps them most often. And just 16% tell us that it's unpaid family friend or a volunteer. When we think about who helps, it's also important to understand if there's someone else who steps in when someone needs assistance. And we do see that a majority of those we speak to say they do have a second person who helps them. So that's 73% say they have a second helper. We know that turnover, as Val mentioned, is such an important thing that people are dealing with on an ongoing basis. We often talk about this at the system level, but the reality is on an individual basis, this can cause a lot of challenges, finding staff, keeping staff. So we ask people about if they feel like their staff change too often. And this is asked whether someone says their main helper is a paid staff person or if it's a paid family person. So overall, across everyone we interview, 22% say that their paid support workers change too often. Now, it's not surprising that when we look at this by who helps you most, there's a really big difference. So among those who say paid family help them most often, just 10% say that their paid support workers change too often. That rate is 3 times higher among those who say paid staff help them most often at 30%. Again, that's not surprising. Paid family are going to be more stable than paid staff, but it's really important when we're trying to understand these outcomes and what they mean and what we can do about it. So now I'm just going to shift a little bit to talk through some of the outcomes. And we do have some resources that I think are going to be posted in the chat here, and you can always check out our website if you want more information about these. But we took a closer look at a number of areas that we would consider to be person-centered outcomes. And across the board, we are seeing statistically significant differences in these outcomes depending on the type of helper. In other words, these differences are not likely to be due to chance alone. So statistically significant is a way of saying, we don't think this is just chance. We think there's something that underlies these differences, right? So looking at the first outcome, always gets enough assistance with activities of daily living. Overall, very high rate of people say that this is the case for them. So that's 85% overall. But then if you look at the next 3 columns on the screen here, we have paid staff, paid family, and unpaid helpers. That rate is higher. It's 93% for paid family. Paid staff fall in the middle at 86%, and then unpaid is the lowest at 78%. We can go down to the next line. Do services and supports always meet your needs and goals? And again, we see fairly high rates here overall, 72%, but it's higher for paid family at 79%, a little bit lower for paid staff, 76%, and then that unpaid group is 66%, the lowest there. takes part in community activities with others as much as they want to. Overall, 67% of people report this when we survey them. And then when we look again at that helper type, we see statistically significant differences here. This one's unusual, though, in that the highest is paid family and the lowest is actually paid staff here. It's a little bit higher for those who say the person who helps the most is an unpaid volunteer compared to that paid staff there. So you might be asking, well, what about all those other things that we know influence outcomes, like age or gender, race, ethnicity, mobility? How much support do you need? Do you live alone? We did account for all of that in the analyses we did, and we're still seeing these patterns hold up. We are still seeing that when you compare those whose main helper is a paid staff, those who say my main helper is a paid family member or a paid friend, they are 2 times more likely to always get enough assistance with those activities of daily living. They are 1.5 times more likely to take part in community activities with others. And they are 1.2 times more likely to say services and supports always meet all their needs and goals. So we're still trying to figure out how to make sense of all of this. But we were really excited to see such promising outcomes for people who are using paid family, as we know this is an important area for states as they explore how to balance demand with the capacity of the existing workforce. And with that, I am going to turn it over to Laura to talk a little bit more about some of our IDD data from family surveys.
Thanks, Lindsay. Again, welcome this afternoon. I'm going to talk a little bit about IDD specific data. You may know that NCI IDD has a trio of family surveys that states are able to administer as part of their NCI membership. And these surveys are mail-out surveys that are mailed to family members and caretakers of families of people receiving DD system services. And the goal of this survey is to kind of try to understand the experience of the families in the service delivery system. So these surveys are answered by the family or the guardian of the person who is receiving at least one service in addition to case management. And we have 3 types of surveys: 2 adult surveys, 1 survey that is sent to families of children. The adult surveys, one is for an adult who's living at home and receiving services, and the other one is for families of adults who do not live at home and receive services. So we do gather information about paid family caregivers through our family surveys. Next slide, please. So in the 2023-2024 data collection cycle, we had 13 states that did participate and use some of our family surveys, and we reached over 18,000 families, closer to 19,000 families. And you can see the states that participated in 2023-2024. And of the people who responded, 65% of them said that their loved one had a diagnosis of intellectual disability, and 44% of them said their loved one had a diagnosis of autism spectrum disorder. 57% of the respondents were white, 22% were Hispanic or Latino, 12% were Black or African American, and 10% were Asian. And 50% of the families that responded said that a family member is paid to provide support to their loved one. Next slide, please. So you'll see in this data that respondents who say someone in their family is paid to provide services have a statistically significant higher rate of satisfaction with services and getting all services listed in their plan. So you can see the graph over on the right side of your screen. The dark green is representative of families who are paid, and the lighter green is representative of families who are not paid. And Lindsay did a great job of sharing with you what's the difference about and statistically significant means. And so all of these are statistically significant. Always satisfied with services and supports families received. People who have paid family caregivers are more likely to be always satisfied. Family member gets all the services listed in their plan. Paid family members of people who have paid family are more likely to get all the services listed in their plan. And finally, you'll see that those who have paid family caregivers are more likely to feel like that the services and supports they receive help the family member live a good life. So there is quite a difference that we're seeing in the family surveys. Next slide, please. Among those who do not have paid family caregiving, 30% of them say that their family member does not get all the services and supports that they receive. And if you dig a little bit deeper in the adult family survey respondents with unpaid family caregivers who said they had unmet needs, the percentage reporting each type of unmet need. So 44% of those families in the adult family survey who do not have paid family caregivers said that they had an unmet need around respite. 36% that they had reported they had an unmet need with having regularly scheduled support staff. So staff being there when they need them. 29% said that they had an unmet need around counseling, and you can see the rest. Homemaker services, almost 20%. 18% no family-to-family networks. And so you can also see, again, there's a difference in unmet needs for those who do not have paid family caregivers. Next slide, please. And you can see again, access to and quality of respite varied significantly for those with and without paid family caregivers. On the left side of the screen, you can see that people having access to respite when they were needed. The first bar is people who have no paid family caregivers, and the second bar there is people who do have paid family caregivers. Those who have no paid family caregivers responded 29% that they always have access to respite when they need it, while 36% of those with paid family caregivers said that they always have access to respite when they need it. Another difference we found was the satisfaction with the quality of respite in the past 12 months. Those without paid family caregivers, 57% said that they were always satisfied, while those with paid family caregivers, 63% said that they were always satisfied with the quality of the respite in the past 12 months. Next slide, please. So with that, I'm going to turn the time over to David, and he's going to talk to us about some things that are happening in Georgia around paid family caregiving.
Thanks so much, Laura. And thanks to Advancing States and to the NCI team for inviting Georgia Department of Human Services, Division of Aging Services to participate in the Sarah Taub Memorial webinar. It is an honor to be here with you today. Next slide, please. So back in 2024, DAS contracted with the University of North Georgia's Institute for Healthy Aging to do a study of Georgia's respite care landscape. I'm really excited to share some highlights of the study with you. Today, I'm going to focus on the home and community-based services for caregivers and the return on investment, or ROI, for funds spent on caregiver respite programs in Georgia. Next slide. So the word respite means offering short-term substitute care for the care receiver by a professional caregiver, so the family caregiver can have a break to do self-care, rest, handle personal matters, or whatever they need to do is not possible while caregiving. Respite care helps reduce burnout and stress of the caregiver. Here's a picture of the respite study team. I'm in the back, second from the left. Our section manager of program integrity at DAS, Arvin Brown, is in the back right. And in front, holding the copy of the white papers, are DAS Assistant Deputy Commissioner Mary Lee Boatwright Quinn and University of North Georgia Principal Investigator Dr. Pamela Elfenbein, and the rest of the UNG respite study team. It was great working with them. Next slide, please. This slide shows that DAS supports a variety of caregiver services. So the chart shows by color how University of North Georgia ended up grouping like services for the purposes of examining the data. For instance, you can see in green all the various types of material aid that we provide is grouped together into one overall material aid category. The services towards the bottom of the list, including respite care in-home and respite care out-of-home, are where the largest portion of caregiver funds are spent. Respite care in-home is usually a professional home health care aide performing homemaker or personal care tasks for the care receiver. Respite care out-of-home is generally when the care receiver attends an adult day program. All services in the data set we shared with UNG were caregiver services. And so to clarify, what that means is personal care, homemaker, and adult day services for those clients who don't have caregivers, or when the caregiver was not the client for respite care, were not included in the data set. Next slide, please. Okay, here is a slide showing funding by regions throughout Georgia. There's 12 AAAs, area agencies on aging, blend and braid fund sources to pay for the range of services for older adults. The amount of dollars that the feds allocate to Older Americans Act Title III-E caregiver services is represented by the darkest navy blue line in the middle of each of those bars. You can see on its own, it's a relatively small amount compared to other funds. So caregiver is just that navy blue slice in the middle. We do have additional state level funds like Alzheimer's Program State and CBS Respite Care funds that AAAs have the flexibility to use them for caregiver respite. For our next state plan on aging, which begins in 2028, we hope to increase the focus on caregiver services, specifically respite care, and showing a positive return on investment for these services advances that goal. Next slide. Here's just some overall numbers about caregiving in Georgia, and it shows the importance of caregiver services. The AARP report, Caregiving in the U.S. 2025, Caregiving Across States, says that 24% of adults in Georgia, it's approximately 2.5 million people, are family caregivers. Family caregivers provide largely unpaid and unsupported care to older parents, spouses, and other loved ones. According to the Governor's Office of Budget and Planning, Georgians over the age of 60 represent 18% of Georgia's total population and are growing at a faster rate than the population of Georgia as a whole. By 2034, the number of adults aged 60 and over is expected to reach over 3 million people, representing 20% of Georgia's total population. Next slide. So this is kind of a condensed version of the overall deliverables for the DAS agreement with UNG. We had a lot more bullets, but we were looking for a general picture of the landscape of respite care in Georgia and other southeastern states, including best practices. We wanted to analyze return on investment for caregiver services funded during the state fiscal years 2017 to 2024 using Division of Aging Services data regarding caregiver care receiver dyads during that time period. University of North Georgia would present their research results in the form of a white paper. Next slide. So here's kind of an interesting demographic portrayal of the state. The data set was de-identified and anonymized all clients for HIPAA privacy purposes. So we did not share any protected health information with UNG. They were de-identified flat files. And this is why the residential data is only represented to a 3-digit zip code, not 5 digits. HIPAA compliance. But on this slide, you can see the first image shows higher overall numbers of older adults are concentrated in the Atlanta and Savannah areas, the dark portions on that first image there. But if you look at the second image, that shows higher total percentages of the population aged 60 and over are concentrated in more rural areas in the northeast, middle, and far southwest corners of the state. We're all familiar with challenges of rural health care. This graphic highlights the importance of bolstering support for family caregivers in those rural regions. Next slide. So this slide shows scores on the Determination of Need Revised, or DON-R assessment that is given to care receivers in the study. The DON-R measures impairment on activities of daily living and instrumental activities of daily living, ADLs and IADLs. ADLs are the basic tasks required for self-care and independent living. That's eating, dressing, bathing, grooming, transferring incontinence. IADLs are a more complex series of life functions such as managing money, telephoning, preparing meals, laundry, housework. IADLs require an application of judgment and higher level cognitive capacity. So on the diagram there, the red line shows the impairment score to qualify for nursing home referral. This is an important measure for determination of ROI in our study. But it does show that this is who our family caregivers are caring for, people with high acuity whose needs exceed the level required for nursing home placement. If you look at the top 40 percentile, the scores are double on the DON-R, the minimum required for nursing home referral. Next slide. The caregiver assessment tool used in Georgia is the Bacchus Caregiving Outcome Scale, which call it the Bacchus. This assessment measures perceived life changes as a caregiver experiences due to caregiving. Overall, those receiving caregiving services in Georgia report that caregiving for them has had negative impacts in many areas of their lives, scores ranging from 63 down to 27. Male caregivers report a slightly lesser caregiving burden reflected in their slightly higher Bacchus scores at all percentiles. The blue column is male on that slide. Next slide, please. So we looked at data points of age, gender, and the assessment scores on both caregiver and care receiver assessments over a total of 22,731 individuals. Once we reduced the data set to where we had all three measures for both caregiver and care receiver clients in the dyad, we ended up with 2,691 full dyads, 5,295 individuals. This data subset did closely resemble the full data set for age and gender representation. So there's a representative sample, those dyads that we had full data points on. Next slide, please. So here we're looking at one way of calculating ROI. Using the Monami data system, Advancing States had produced an infographic. The value of aging well, the Older Americans Act, create real returns through community-based care, and they provided a return on investment calculation, a way to calculate that. Monami calculated days of long-term care avoided using, in part, formulas and studies by Johnson and team and Jorgensen and team. And those studies showed that 15% of older adults spend more than 2 years in a nursing home, and that every hour of service provided per client per week results in a 6% decrease in the risk of entering residential care. Next slide. So the University of North Georgia utilized the Advancing States Monami model to produce what they consider a rather conservative estimate of return on investment for caregiver services during the state fiscal year 2024. So in 2024, there were 636 care dyads who received 618 hours of case management. See over $104,000 of respite personal care, that $2.7 million spent, which by the model resulted in over 13,000 extra days in their community, estimated dollars saved, $3.8 million. So 41% return on investment using a conservative model there. Next slide. Here we used an additional model to estimate ROI for DAS caregiver services provided during state fiscal year 2024. In this model, adults 80 years of age or older with 3 or more ADLs with levels of impairment 2 or greater, including bathing and dressing impairments, would most likely require nursing home placement if HCBS were not available. So if we are to consider only those 115 dyads, clearly the most likely to be in a nursing home based on literature as being diverted from a Medicaid nursing home bed for 1 year. The extra days in the community amount to 41,975, and the cost of Medicaid nursing beds during that time would be $8.5 million saved. So by these two models, we believe that each of the preceding calculations substantially underestimate return on investment for dollars spent on home and community-based services in Georgia. Next slide, please. So to summarize, the 2 ROI calculation models in the study, calculations were based on either the advancing states formula or calculating days saved in the community by meeting the most stringent benefit triggers and risk factors identified in the literature. The advancing states calculation does not include severity or types of impairment or consider known risk factors for nursing home placements. It's very conservative. The study found that every dollar invested in respite care generates dollars saved in avoided long-term care costs, underscoring the economic efficiency of caregiver support programs. Next slide. The study concluded that respite care is essential to sustaining the much-needed family caregiver infrastructure that supports community living for older adults and adults with disabilities. Analysis of the data shows that HCBS caregiver services in Georgia are taking care of the right people and providing the right type of support to keep them in the community. Expanding those services will strengthen our HCBS network and be an effective return on investment. See, on the right side of this slide is a word cloud of the most said words during 90 interviews of Georgia caregivers. I thought it was an interesting qualitative component in the study. You see that caregivers need help. Next slide, please. So the final study recommendations include strengthen caregiver navigation and access to resources, expand respite services for underserved populations, those in rural regions and with the highest impairment and caregiver burden scores, enhance ROI measurement and tools, adopt best practice guidelines from the Administration for Community Living, advancing states, USA Aging, and other states. Address workforce shortages through innovative strategies, which was discussed earlier. Next slide, please. Here's the links to the study. It's posted on our website, Georgia Respite Care Study link there, and there's a direct download link to the white paper, direct download link to key findings. Next slide. That's all I have. Thanks for letting me present, and I'm glad to answer any questions after the wrap up.
Well, this has been a lot of information and hopefully useful to all of you watching today. Just to wrap up, some state and federal initiatives to strengthen family caregiving, both paid and unpaid. First of all, the ACL investment and prioritization of family caregivers, which started in the last administration and continues in this administration. The RAISE strategy to support family caregivers, and now the Caregiver AI Prize competition. Second, communities of practice to support families across the lifespan. Certainly NASDS has had a community of practice for family support for many, many years, which has really helped to enrich and strengthen family caregiving around the country. Medicaid structured caregiving, SFC, and the Medicare guide model. These slides are available, and there are links on this final page. Next slide. So here is the Facebook page for National Core Indicators and our website, where you'll find data on both NCI ID as well as NCI AD. And we want to thank you all for your attention and participation today. And now we'll welcome questions. So, friends, Lindsay, we don't have any questions, so shall we say goodbye?
We could launch the evaluation as people are hopping off to
Great.
hopefully get a little bit of feedback.
Well, actually, Val, there is a question in the chat from Vicky who asked, how do these indicators actually assist us in providing better lives for people with disabilities? And I can't think of a better person to answer.
Oh, you're going to pass that one to me.
Oh, yes.
Well, the intention of National Core Indicators going back to the 90s when NCI was born was to find out whether this investment, which our friend David just discussed, that we're making in all these services was in fact having an impact on the lives of people that states were providing support to. It was very important for them to know whether this new community system that was spreading across the country was really succeeding in improving people's quality of life. So we tried to think about all the domains in which quality of life can be found, whether it's employment, whether it's relationships, whether it's involvement in your community, a sense of belonging, hopefully removing people from isolated situations. And as the years have gone on, states have been able to track those outcomes across their service systems, identifying areas where they've been able to improve, but also identifying areas where they need more work. So states have been great about looking at their data. Let's say people aren't getting sufficient transportation to get to places they want to be. So forming committees, groups of stakeholders to discuss ways in which transportation, for instance, might be improved. And we certainly hope and believe that by hearing the voices of people with disabilities, that states have been able to improve their service systems over time rather than just staying where they were. And I think some of our longitudinal data does suggest that lives have been improved as a consequence of understanding people's circumstances. Anybody else on the NCI team who wants to weigh in on that?
No, that was magnificent.
Yeah, I thought you did a great job, Val. I think one of the things we often suggest to states and advocates is to kind of find where you have shared priorities. When you're presenting data to the state, if you can find a way that it reflects some of the initiatives that they're working on too, I think there's often been more interest in trying to figure out how to move the needle on some of those areas, right? So there was also a question in the chat, Q&A, about differences in satisfaction with paid family caregivers based on any other factors. We did not, for the study that I pulled the data in from, we did not actually look at the satisfaction variables. We were looking at those person-centered outcomes. However, I think the reality is a lot of those do have kind of a satisfaction element when you think about people saying that they're not having all of their needs met, or if they need more support for ADLs. So I think it's definitely connected conceptually to satisfaction, but for that specific study, we did not look at the satisfaction. For the aging and disabilities study, for the data that Laura shared, which was from the NCI IDD adult family survey, that we did see quite a difference in satisfaction. So it'd be interesting to go back and look at some of those satisfaction variables, given that the IDD data suggested that there might be some evidence of those high rates of satisfaction as well. I see another question in the Q&A that I'm wondering, kind of Rosa, if you would want to respond to around the lag with HCBS services.
Yeah, I was starting to type an answer. This is a really good question, and it's not one that I have an easy answer to because states vary so widely in what sort of services they have available for those who are on a waiting list. They might have some, for example, like a 1915C with some supports for some people who are on the waiting list. Other states may be at entitlement, as you know. And I just haven't done that comparison to see what kind of services are available and the wait time between them. But it is one that is a really interesting question. So if anybody does have more specific information on that, I would encourage them to share information on what may be available in their state. And I apologize for not knowing specifically how long the waiting, list would impact that.
Thanks, Rosa.
Thanks, Rosa.
There is another question that came in. I'm wondering if Lindsay, you want to take this. Wondering if the type of family member or type of or nature of payment program had better or worse outcomes or extent of caregiver training that comes with payment.
Those are really, really good thoughts that we can look into further. We collapsed. So it's paid spouse or family member, and then there's another category for paid friend. So we could split that up a little bit more. And then we do have information on the NCIAD on kind of the waiver, like if people are getting aging waivers or physical disability waivers or combined waiver, or there's some variety there, and we could look further at that as well. So those are some really good thoughts. Thank you, Eileen.
And Lindsay, can you mention a couple people want to sign up for the NCI newsletter? Can you just let them know? We'll take those emails, but how will they know that they are officially on the list?
Yeah, we will take your emails. Another way, since we did pull that QR code down a little bit, the NCA IDD website actually has archives of the previous editions of the newsletter and a place to subscribe. So if you go to the IDD website, the section called News should allow you to subscribe. It comes out quarterly or close to quarterly. So I think the next one should be coming towards the end of this month or in early April. So if you haven't heard from me by the end of April, feel free to reach back out and just make sure that I did add you to that list. But I will be adding anybody who registered and opted in, and then people who put their name in the chat here, I will add you as well. Thanks. I was going to say, I'll read off the chat from Alex here. In response to the question about contracts to find all options for caregivers, one place to check out is the Arch Respite. It's I think a national coalition looking at respite. So that's linked here in the chat. It's archrespite.org, Arch spelled ARCH. And Heather put a link in the chat as well for our newsletters for anyone who wants to check those out for the old editions and subscribe. And some other comments in the chat saying thank you for the webinar. You're so welcome. We're glad you were here with us.